Thank you, Professor Katayama. As a sign of respect to our chairman and his compatriots, I would like to start by paying tribute and extending my sympathies to the victims who died at Fukushima. And I hope that disaster never happens again, neither in Fukushima nor in Japan or anywhere in the world. The question is, all pediatricians should start treatment with levodopa and go slow, yes or no? And I'd like to start by summarizing what the two speakers said, borrowing some of their slides. First, why early L-DOPA? Professor Stocky said agonists work, have lower frequency of motor complications, but they are less efficacious than L-DOPA. They have their own risks, sleepiness, edema, impulse control disorders, and so on. And they do not really abolish the risk for motor complications. They simply delay it. And in long term, all patients will develop motor complications independent of the initial treatment. Now, I allowed myself to put this slide up. This is from the English study in which patients were started on bromocriptine or on levodopa, and as needed, other drugs were added. And after 14 years, any dyskinesia was really not so different. Any fluctuations, not much different. So the conclusion was, after 14 years, it doesn't matter which drug you started, patients will end up in the same place. So the argument, and especially supported by clinicians from Mayo Clinic, for example, as several American experts joined that, if L-DOPA is the most efficacious drug, and if all patients will end up in the same place, why wouldn't you start with L-DOPA? In addition, as Fabrizio showed, STRIDE-PD sub-analysis suggests that it is a matter of dose, it's a matter of some risk factors. If you can start low, go slow, you can reduce the risk of motor complications. You should be careful with the profile of your patients, you should be careful with your dosing, and I remember the early days when L-DOPA complications were described. I was a junior, and David Marston, who I had the pleasure to spend some time with, he said, well, after L-DOPA was introduced properly with a carbidopa, Americans were talking about these complications, and we had no idea what they were talking about. And as usual, the Americans were giving larger doses as compared to Europeans. And the question is, should you delay better efficacy because of fear of motor complications, which may occur in 5 years, 10 years, and in some patients which will not occur? So these are his arguments. Now, Cenk started seemingly feeding into the hands of his opponent. He said, why would you ever think of using other drugs other than L-DOPA? He says it's the drug with most favorable symptomatic control, associated with best quality or better quality of life. Side effects like dyskinesia, frequently preferred by patients, at least in our part of the world, to poor symptomatic control, and generally accepted to be free of awkward side effects like impulse control disorders. And in his own cynical way, he said, in fact, if you use agonists, you can help national economies. And then he quickly switched, turned around, and he said, well, this is the reason why you should not start with L-DOPA, because any study which compared an agonist with L-DOPA showed that dyskinesia is about twice as much, wearing off is twice as much. So motor complications, fairly reliably proven to be more frequent with L-DOPA. And if you start with an agonist and L-DOPA is added whenever needed, dyskinesias and wearing off will be less frequent. And he argued, again, what is the relevance of these? Shall we try to avoid them? He followed up with his question, why would ever someone want to use any drug other than L-DOPA? He said, yes, agonists, because you can delay the emergence of dyskinesias and wearing off, and when you have the need, just add L-DOPA, nothing wrong with that. And he also said, if the patient is early enough, had mild disease, you can consider MAO-B inhibitors and add the others as needed. And he showed this as an optimized strategy: mild patients starting MAO-B inhibitor, progression, adding agonist, and if needed, adding L-DOPA. So what I think about this, I agree that with all we know, levodopa is the most efficacious drug, and it also has a better short-term tolerability when you consider orthostatic hypotension, sleepiness, edema, and so on. L-DOPA, in general, is better tolerated than agonist. The problem is long-term complications. And we know, despite other side effects, which can be problematic, which can provide other risks, they delay the risk for motor complications. They do not abolish it, but they delay. So I agree, there's no harm in starting with agonists, in particular in young patients, and keep them as long as needed on agonist. But do not hesitate to add levodopa as soon as needed. Now, I think this is the critical point when I try to reconcile the two viewpoints. Add it as soon as needed. Age is not an issue if there is not enough improvement on other drugs. And that's a problem I encounter in my own practice, that you see young patients, they are in bad condition, they are on maximum dose agonists, sometimes combined, and they are still not given L-DOPA because people are worried that L-DOPA would harm them. Do not wait until patients become really dysfunctional. Cenk Akbostan is a nice saying, don't wait until they use their job, their wife, their life. So as soon as you realize that there's a need, do not hesitate. In fact, levodopa phobia is a proper iatrogenic disorder and should be avoided. Starting with low dose and going slow, in fact, reduces the risk. As you've seen in STRIDE-PD sub-analysis, this is as careful as you can get with data. STRIDE-PD was designed to seek motor complications. So those motor complications were properly assessed regularly, so as good as you can get to real life, how much it happens, when it happens at STRIDE-PD. And it shows if you are at lower doses, the risk is substantially reduced. Therefore, L-DOPA should be carefully dosed, only as much as needed. Do not try to overdose, and that was one of the problems in STRIDE-PD, that at higher doses in early stage patients, they were virtually given twice as much as they needed. And I think the improved dose formulations, the triple combination, levodopa, carbidopa, and tacapone, as shown by Fabrizio, gives possibility for fine-tuning, and in particular, the spectrum of dose strengths. If you have 6 dose strengths, you can titrate patients and fine-tune patients in terms of dosing and give as much as needed, but not more, without having the trouble that you have to break the tablets to quarter, halves, and so on. So this is my reconciliating view and comments that yes, in younger patients with mild disease, there's no harm in starting with MAO-B inhibitors or agonists, but be aware you have to give the patients their proper treatment as much as they need it and use the proper tools. Mr. Chairman, this is my comments. Do I stay here or take the, do we have the discussion from here? Joining everybody here?